Hello, everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own medical oncologist, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers to access the right treatment at the right time. November is observed as Lung Cancer Awareness Month, a time which is dedicated to educating the public, supporting the patients, and highlighting advancements in lung cancer care. Despite being one of the most common cancers worldwide, lung cancer outcomes are improving significantly due to rapid progress in early detection, precision diagnostics, and targeted therapies. So, today's session, Breathing Easy, What's New in Lung Cancer Diagnosis and Treatment, is going to bring you insights on the latest breakthroughs from innovative screening methods to personalized treatment approaches. Whether you're a patient, a caregiver, a healthcare professional, or simply someone who's looking to stay informed, this discussion aims to empower you with a clear, updated, and practical information. Joining us today is Dr. Krishnamani, one of the most respected voices in oncology. He has been associated with AY hospitals here in Hyderabad since more than a decade. He is known for his expertise in managing solid tumors, blood cancers, and oncological emergencies. His journey spans international fellowships and leadership roles at some of India's top cancer centers, giving him a truly global perspective on cancer care. He's also contributed immensely to the field, from shaping cancer treatment protocols to influencing cancer care policies and driving research that makes a difference. But what really stands out about him is his compassionate and patient-centered approach. We welcome you to today's session, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And today, let's talk a bit about lung cancer, which is one of the commonest cancers we see in our day-to-day practice.
So, sir, can you just begin by telling us about the common types of the lung cancer which are there? What are the risk factors which causes it?
Okay, so for beginners, what is lung cancer? Cancer which starts in your lung. How common is it? It is the commonest cancer seen in men in our country and also in the world. And it's a deadly cancer. The disease-specific death or mortality we say is 80% to 90%. So it is that high that patients usually present in an advanced stage and usually die of the disease. Now, what is the cause? One of the most important cause is tobacco and BD and chutta. So from a cancer reach perspective, what we always aim is cancer prevention. That is why we talk about awareness and prevention. So if you want to stop lung cancer, stop smoking cigarettes, BD, chuttas, hookahs, e-cigarettes, whatever you call that. So tobacco is responsible for lung cancer, period. The risk increases with the number of years you smoke. One pack of cigarettes usually has 10 cigarettes. So we quantify a person's smoking by pack years. So suppose somebody smokes one pack a day for 20 years. He has smoked 20 pack years. One pack a day for 10 years, 10 pack years. Two packets a day for 30 years. 2 into 30, 60 pack years. The more your pack years increase, the more a risk of developing lung-related problems, including lung cancer. So somebody who has smoked 60 pack years, that could be 4 packets a day for 15 years, or 6 packets a day for 10 years, or 2 packets for 30 years. Somebody who has smoked 80 pack years, the higher the pack years, the higher the risk of developing lung cancer. No doubt about it. Now, apart from smoking, indoor pollution is an important cause today, what we see. Passive smoking or secondhand smoke. So if I am inhaling this cigarette smoking of some of my near and dear ones daily, then I am at risk because I am also inhaling that tobacco. Work in coal factories, asbestos factories, so occupational exposure, that can lead to lung cancer. And sometimes we really don't know the reason for development of lung cancer. So stop smoking, take precautions at your workplace, avoid secondhand smoke or passive smoking. Now, extremely common cancer, most common cancer in men all over the world and in India, and highly generally presents in an advanced stage, stages 3 and 4. What are the types, you asked me? Types are broadly two: small cell, non small cell. Small cell is seen exclusively in smokers. Small cell generally presents in an advanced stage. In an advanced stage, the survival of small cell cancer is usually less than 1 year. Non small cell is the commonest variety. In that, there is something called squamous, there is something called adeno, there is something called large cell, there is something called neuroendocrine, etc. So, broadly, these are the two types: small versus non small cell.
Sir, does lung cancer follow any genetic lineage? Like, for example, if the father has had lung cancer, would the offsprings also be prone to having the cancer?
So, the risk of familial lung cancer is maybe less than 5%, I think. There are a lot of genes associated, but there is no specific, uh, what do you say, uh, specific basis to say that lung cancer is genetically inherited. The causes which I told some time back, like smoking, occupational exposure, secondhand smoke, are the most important factors.
So, can you walk us through the signs and symptoms that these patients face?
So, signs and symptoms are your respiratory symptoms, which are pretty non-specific. Somebody may come with a cough, a dry cough, or sputum, or cough with blood in the sputum. They may come with breathing difficulty, breathlessness. Initially, the breathlessness may be on exertion, on walking stairs. Finally, the breathlessness may be at rest also. When they're even sitting and talking, they're unable to talk. Weight loss, loss of appetite. If the disease spreads to the brain, they may develop seizures or weakness of the limbs or double vision. If the disease spreads to the liver, they may present with pain in the right side. They may present with jaundice. The disease goes to the bones. They may present with bone pains or back pains. So, cough, breathlessness, uh, sputum being red in color, and chest pain. Sometimes when the disease is locally invading, then they may have pain in one side of the hand. Sometimes what happens is the disease may compress the main blood vessels which go to the heart, because of which the patient develops puffiness of the face, the tongue becomes swollen, they become drowsy. That is called superior vena cava syndrome. There is a large vessel called a SVC, superior vena cava, that comes from the heart. So if that is blocked due to this, the blood circulation is not happening, the face is puffed up. So these are all the common symptoms. And the final common symptoms are weight loss, loss of appetite, and if it spreads to the bone, brain, and liver, you have those associated symptoms.
So, can you list out the diagnostic methods which are used to diagnose lung cancer in patients?
So, as we always discuss on Cancer Reach, our diagnosis is based on test to confirm my diagnosis, which is going to be a biopsy. So, lung cancer, you may have a mass here, but you may have a lymph node here. So, you will do a biopsy from here. Why do you want to go into the lung and cause injury to the lung? So, I will do a biopsy from an accessible area. This is to confirm the diagnosis. Then, test is to stage the disease, where all my disease has spread. I'll do a CT scan of the chest, abdomen with contrast, or I will do a PET CT scan and a bone scan. Then finally, tests to know the general health of a patient, which includes your complete blood picture, kidney, and renal function test. Apart from this, in stage 4 lung cancer, or even in early stages nowadays, on the tumor, you do something called immunohistochemistry to say whether it is small cell, non-small cell, non-small adeno, squamous, etc. And after immunohistochemistry will tell you if it is adeno, whether it is squamous. And after IHC, you are going to do something called molecular typing, which is looking for certain mutations which are seen in lung cancer, like EGFR mutation, ALK mutation, ROS mutation, PDL1. If these mutations are there, they receive their specific treatment. So my diagnosis is with biopsy. On the tumor, I will do an IHC and later send for a molecular panel. My staging is with the PET CT or a CT scan. My general blood tests are CBC, RFT, LFT. This way, I diagnose a patient with lung cancer.
So, can you tell us about liquid biopsies and how they are changing the treatment for lung cancer patients?
So, what is a liquid biopsy? Liquid biopsy means you are taking blood and sending the sample to look for these mutations. When do you prefer a liquid biopsy? When your tissue is not available, or when it is very difficult to access a tissue, or the patient doesn't want to give a consent to do a biopsy because he or she is scared of the post-procedure complications. Then you send the liquid biopsy. But for diagnosis, you always would prefer a tissue. Liquid biopsy is more during follow-up. Whether the disease is, if the cells are going up in the liquid biopsy, then it means probably the disease is going to relapse very soon. Liquid biopsy is used to check for these mutations which you want to do, but you don't have tissue or you cannot get tissue. So liquid biopsy at diagnosis is not a substitute. You need a tissue biopsy, but at follow-up, maybe liquid biopsy can be done.
So, are there any advanced imaging techniques which are used for lung cancer diagnosis?
So as far as imaging is concerned, you go for very good contrast enhanced CT scan with bone scan or a PET CT scan. For the brain, you would do an MRI brain with contrast. These are more than enough. Other tests which help you in diagnosis are a test called bronchoscopy. Sometimes you may have a lung mass in the central part, which you cannot do a CT guided biopsy. You will put a tube to the mouth into the airway and go into that area and take a piece. That is called a bronchoscopy or an EBUS guided biopsy. Endobronchial ultrasound, we say.
So, we recently discussed about the molecular or the genetic profiling for these patients. So, which kind of genes are more in Indian lung cancer patients?
So Asian or Indian non-smoker adenocarcinoma will have EGFR or ALK mutations. EGFR is epidermal growth factor receptor. ALK is anaplastic lymphoma kinase. So if you're a man or a woman from Asia or India who doesn't smoke, who has adenocarcinoma, your tumor has high chance of being EGFR or ALK positive. If you are EGFR positive, you are given a specific tablet. If you are ALK positive, you are given a specific tablet. Elderly patients can avoid chemotherapy and go for these tablets. These work better than chemotherapy and excellent quality of life and improve your survival.
Sir, can you walk us through the treatment options which are available for the early lung cancer patients, like say stage 1 or stage 2 patients?
Early lung cancer, what is early lung cancer? That means lung cancer which is limited to the lung. It may have not even gone to the lymph nodes. So you have to do a lymph node evaluation. You will check there is no disease here, it is only here. If possible, go for surgery. Why I say if possible? It's a major surgery. The patient should be fit for surgery. After surgery, you will require chemotherapy in stage 1B and beyond. After surgery, if you are EGFR positive, you will be put on a tablet called osimertinib. So the basic thing in early lung cancer is very, very uncommon, maybe 10-15%. Cure, you should emphasize on cure. But for early lung cancer, the most important treatment is surgery, but the patient should be fit for surgery. If he's a chronic smoker and his lungs are damaged due to COPD and you are going to remove that part of the lung, he will not tolerate the major surgery. So that is important.
Sir, what about radiation therapy? Is it used for lung cancer patients?
So in early stages, radiation is used in those patients whom you cannot send for surgery. If they have a peripheral lesion sitting where you cannot operate, or they're too old that you could not operate, you can give radiation called SBRT. In advanced stages, radiation is given to control the symptoms, control the bone pains.
Sir, when we talk about treatment options for advanced stage patients, what are the frontline treatment options that you give to your patients?
So understand very clearly, we are talking about advanced stage 4 lung cancer. It is not curable. You are trying to control the symptoms, improve the quality of life, and prolong the life. So when you have an advanced cancer patient, look at whether it is. So we are talking mostly about the non-small cell variety. So non-small cell lung cancer, stage 4. Do a biopsy. Send for EGFR, ALK, ROS, etc., and PDL1. These mutations are called driver mutations. So if somebody is EGFR, ALK positive, ROS positive, they are driver mutation positive. Put them on the specific tablet. EGFR osimertinib, ALK alectinib or lorlatinib, ROS crizotinib. So these patients, you can avoid chemo. Nowadays, we also add chemo, but ideally, that mutation is driving the cancer. That is why it is called driver mutation. Stop the driving by giving the tablet. If the patient is fit, give chemo also with the tablet to get maximum benefit. Now, somebody is driver mutation negative, they will not receive those tablets. If they are PDL1 high, they will receive immunotherapy, 1 to 50%. PDL1 score is above 1%, you will receive immunotherapy with chemo. If the PDL1 is 0, you will receive only chemo. So my options are chemo, immuno, tablets. So tablets if I am driver mutation positive, immunotherapy if my PDL1 is high, chemotherapy if I am driver mutation positive also you can give, negative also you can give, with or without immunotherapy also you can give. So these are your broad treatment options for stage 4 advanced NSCLC non-small cell lung cancer.
So, can we get information about the side effect profiles of targeted and the side effect profile of immunotherapy molecules?
So osimertinib, for example, it's a drug of choice for stage 4 EGFR positive lung cancer. It works inside the brain also. That is the beauty of osimertinib. It has intracranial activity. So if you have lung cancer with brain mets, which are small, you can avoid radiation and your drug will go into the brain and work. Side effect profile, very safe drug. You may develop an acne rash, some dry skin, some diarrhea, sometimes some fatigue. Very, very beautiful, safe drug. ALK, alectinib, extremely safe drug. Check for liver enzymes, ECG abnormalities here and there. Lorlatinib can sometimes call visual hallucinations. Patients see something going on the roof, on the floor. They develop visual hallucinations and liver function abnormalities. Immunotherapy can lead to rash, can lead to dermatitis, can lead to loose motions, colitis, can lead to breathing difficulty, pneumonitis, can lead to thyroid problems, can lead to autoimmune problems like anemia, and so on and so forth, fatigue, etc. So that is the side effect profile of the IO drugs or immunotherapy drugs.
Sir, can we discuss about the prognosis of non-small cell as well as small cell lung cancer?
So small cell advanced has a significantly poor prognosis, less than a year, or hardly 12 to 14 months. Non-small cell, I'm telling you now, EGFR you can take. Survival is ranging beyond 3 years or 4 years. ALK, 3 to 5 years and beyond. So these drugs have all reached 4 years, 5 years time period. If you are driver mutation negative, PDL1 negative, your survival is maybe 2 years or less than 3 years.
Sir, when we talk about prevention strategies for lung cancer, are there any screening methods which can be employed among the general population?
Low dose CT scan once every year or 2 years is recommended for patients who are chronic smokers. But if you ask me, stop smoking. That's the best thing to do. So the best prevention is stop smoking, no tobacco, no pan masala, no smoking, sorry, no BD, no chutta.
So, what are the other prevention tips that you would like to give our audience for lung cancer today?
See, pollution is rampant. So protect yourself, wear masks wherever you go out, try to avoid crowded areas. This is not for lung cancer specifically, but generally, obviously avoid secondhand smoke and quit smoking.
Sir, are there any other advancements which you would like to inform us about regarding lung cancer, be it in the diagnosis or for the treatment part of it?
So We have come to NGS in lung cancer, where we do this multi-gene panels. Beyond EGFR, ALK-ROS, we are looking at other genes also, RET, MET, HER2, etc. So that is an advancement. More the mutations, more the medicines we have to treat lung cancer. Treatment, we already spoke about immunotherapy, we spoke about TKIs, we spoke about chemotherapies and those kind of things in lung cancer. Imaging, PET MRs, and all that is being used in lung cancer. So the last 10 years has been exceptionally good for lung cancers, 15 years especially. There's been so much change that patients' quality of life and survival has improved tremendously.
Sir, can you summarize this entire session for our audience?
So, see, lung cancer is the most common cancer we see today, responsible for a large number of deaths, highly preventable if you stop smoking, mostly presents in an advanced or a late stage. Non-smokers do develop lung cancer. They will have EGFR or ALK mutations for which tablets are available. Uh, Early stages are curable, advanced are not curable, but the quality of life can be improved and survival is usually good.
Sir, can you tell the audience about the second opinion campaign which is being run by you?
So, as explained multiple times on Cancer Age, we have a second opinion campaign where uh, we encourage patients who have a cancer diagnosis to come forward and WhatsApp us, and we'll help them out through our WhatsApp and guide them on how the treatment has to be.
Thank you for today's session. Thank you for enlightening us on the latest diagnostic techniques and on the latest treatment paradigms which are changing in lung cancer. We hope to again see you next Friday with another interesting topic. Thank you, sir.
Thank you. Thank you so much.